Welcome, everybody. I want to welcome you to the Resident and Family Support Council meeting that we hold on the 2nd and the 4th Tuesday of every month at 3 o'clock. Always remember the same link that brought you to this meeting will bring you to all of our meetings. And so share that link, share it with your neighbors, your relatives, your friends, share it far and wide, because you never know, a particular topic actually may be of interest to somebody that you don't even realize they might want to know about this information. And also, if you can't make a meeting for any reason, we also record these meetings and we put them on our YouTube channel. And Stephen, I already see that he's working he's working in the background, putting all the links into the chat. So you can see the link for the YouTube meeting in the chat, and you'll be able to access all of our past meetings from there. So it's a really great resource. Again, you can share that information with people because there's such a big, wide variety of topics on there that it can really help people as they're trying to navigate this long-term care path. I should introduce myself. My name is Lee Moriarty, and I'm the Deputy State Long-Term Care Ombudsman. And we also have Stephen Maxwell, who is the guy who works the magic in the chat, as well as Karen Kloppy. There's Stephen. We also have Karen Kloppy. She usually does a lot of, if we refer to websites and things like that, she's Googling away, putting all that stuff into the chat for us as well. So we've got a great team of people working here to make sure that these meetings have some value and meaning for all of you. So today, we're actually going to be talking about dementia. Last meeting, we talked about dementia and psychotropic drug use and how psychotropic drugs are not necessarily the path to go down when people are when they're demonstrating what we might be referring to as a behavior. So we wanted to further that conversation and talk about other things that we can do in order to really understand, put ourselves in the shoes of, and kind of bring this conversation a little bit more to home about how we can show people that have dementia that we really do care about them. I'm going to go ahead and I am going to start sharing my screen now. I'm going to be patient while I find that screen. Okay, so this is not the one that I want. So let me stop that share and let me close this PowerPoint so that I can do the other. Okay. Okay. Also, I did forget to mention that we want to thank the Illinois Pioneer Coalition for providing us with their Zoom account. That's why you see Illinois Pioneer Coalition underneath my name, or instead of my name. They're the ones who allow us to use their account to be able to host these meetings, which is really, really wonderful. And if you want to know more about the Illinois Pioneer Coalition, we also have done some videos, some past meetings on person-directed living. And we're going to be talking a little bit about that today in relation to this topic of understanding dementia-related behaviors and moving from drugs to investigating the why. So in order to put us all on that same page, let's just start off with defining dementia. I'm not going to spend a lot of time on this because I really do want to talk a lot about the experiences that people have when they have a dementia-related diagnosis. But dementia is really just a general term. It's for that loss of memory, that cognition, all of those types of things that can interfere cognitively with people's everyday life. And dementia is not a disease. It's not a diagnosis. It's important that people understand that. Dementia is not a diagnosis. It's a symptom. It's a condition that accompanies different diagnoses. And there are many, many, many different types of dementia-related disorders out there. Alzheimer's is the most known. Then there's things like frontotemporal, Lewy body, vascular. There's a variety of different ones out there. The reason why I'm bringing this point up as we talk about this, talking about behavior, is because different dementias, when they have the diagnosis, come with other symptoms. So somebody who has Alzheimer's versus someone who has frontal temporal will experience their world differently because they've got other things going on, two very different things. For example, frontal temporal, people have a frontal temporal dementia. That's in the front part of the brain and the side parts of the brain. And because of where the brain functions, people that have frontal temporal have a hard time controlling emotions and language processing. So that will be another symptom that they would experience along with the dementia that they experience because they have a diagnosis of frontal temporal. For example, with Lewy body dementia. Lewy body, that actually affects the central nervous system in a greater capacity, so that people have Lewy body will have like Parkinsonian type tremors. They won't be able to have as much fine muscle control because of their diagnosis. So they'll have that along with their dementia. So it depends on what type of dementia-related disorder that you have, what other conditions might follow with that. I bring that up because there's more to what's going on with people when they're given one of these dementia-related diagnoses than cognitive loss. And many times as care providers, we get caught in the cognitive piece. And that's all we focus in on, forgetting about the other pieces that are going on with an individual. Whenever I talk about this, I like to equate it to like cancer. So there's a variety of different types of cancer out there, right? You could have anything from skin cancer to you could have leukemia, two extremely different types of cancer that come with very, very different conditions. But the bottom line is that they both had mutations that started to spread throughout their body. So that's the similarity in that understanding that a group of diagnosis actually, that's what this is. Dementia is a group of diagnosis that all experience that same cognitive piece to it. If people have questions as we're moving along, please do pop them into the chat, or you can unmute yourself, raise your hand. When I'm doing a presentation myself, it's difficult for me to see if hands popped up or everything because of the screen that I have, but Stephen will always interrupt me and say, hey, Lee, we got a question. So know that you can always do that. Again, to put us all on that same page, to understand what somebody with dementia has, is experiencing, I wanted to share this brief part of a YouTube video. I think it's important to hear from people who have a dementia-related diagnosis. I always say the only expert for dementia are those who are living with it. The second person in this line are those who love somebody with it. The rest of us are not experts. The rest of us are just trying to learn and understand as much as we can. But the person who has the disease and the person who loves someone deeply with the disease, they understand this disease better than these diseases better than anybody else. So I'm going to go ahead and I'm going to bring this up, and we're not going to watch this whole thing because it is 13 minutes long, but it is a really, really great video. So because it really does help bring us to that moment. So I'm going to go ahead and just bring this forward a little bit. Okay, here we go.
Months ago, people's names, but suddenly I'd be sat in a meeting and halfway through a sentence, I'd forget the most silly of words. And that was when something hit me that it wasn't quite right. This is where I had my first experience of what dementia.
Sorry, an ad seems to want to pop up into the middle of this.
Get ready for the sale of the summer. Wayfair's Black Friday in July is coming to a block near you. For 4 days only.
I had it.
Dementia can do to your brain. The time I came out of my office and didn't have a clue where I was. And I didn't know who all the voices belonged to that I could hear. I was just lost. I stood here and just froze for a second. I decided to walk away and down the corridor, hoping that no one would come out and say hello or notice that there was something wrong. But I thought if I walked down the corridor, then I would be able to hide away for a few minutes or however long it would take for the fog to clear. And so I went through the end door and into the washroom, because that was the only door. There was a locked door. I stayed in here for what seemed like forever, but it was probably only 3 to 4 minutes. And after that time, it's suddenly like the fog's clearing, the mist has lifted. It makes your heart thump. Let's put it like that.
Did you have a family history of Alzheimer's at all?
No, nothing whatsoever. And I didn't drink, don't smoke, have a wonderful diet, used to run every other day. But I've still got Alzheimer's. We all have our different ways of coping. I've got this thing on my fridge door, put on it each day what I'm supposed to be doing or where I am. I've also got photos everywhere. Here's my daughters. Here's me. Photos always make you feel happy. And we have the ubiquitous pill box. This one's the morning pill box. That's why it's down here next to the kettle. Anywhere else, and I'd forget to take it. When they actually diagnosed me, in a bizarre sort of way, it was actually quite a relief, because it put an end to all the ifs and buts and maybes. It brings a conclusion, an end, if you like, to the not knowing, and a start to the building a new life. For those of us living with dementia, our memories are our most valued possessions. So here in this room, I have pictures on the wall, pictures of people, of family and friends. So when I forget where all these places are, or the names of the people on the pictures, when I stand here and look at them, all I feel is one of happiness. Because when we lose our memories, it doesn't mean we lose emotions that we feel inside. Well, to my way of thinking, you have to think of any positive you can to having such cruel disease. Now, I love Great British Bake Off. Love, 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 love Great British Bake Off. And everybody talks about the sadness and the emptiness when the final comes and you know that it's not going to be up again next week. Well, I can just start watching it from the beginning again and not remember who won or who gets knocked out each week. So I'm never without Great British Bake Off. I have 3 biggest fears. The one is going over the edge into someone else that I don't recognise. The other fear is losing my independence. And the final one is not recognising the 2 people that mean so much to me. I've said to them that, you know, one day I won't know, you'll come in the room and I won't know who you are. I won't know your name, but I'm sure I'll feel that emotional connection of love that we have for each other. And for them to always remember that even though I won't recognise them, I still love them.
And this video goes on and shares some other people's stories as well. And I can make sure that we share these links for this meeting if they can't find them, if my people working in the background can't find them. So let me go ahead and stop this share. and then I'm going to go ahead and continue to share the slides. I'm just curious, as people heard this, if it got you to start thinking a little bit. You know, like I said, I think it's important to listen to people that have this, that are experiencing dementia, so that we can understand it better. Because especially if we're caregivers, if we don't know what it feels like, we're not going to know how to be able to help, how to be able to be there to support. So that's why I feel it's important to talk about this. Some of the things that I heard when I watched this video is how she felt in the very beginning. It was a fog. She knew enough to go to a bathroom, to a locked space, but she knew that something was going on in her brain. I found that very, very interesting. How she coped, how she goes about coping, the way she puts her medication, how she puts the pill box down by her kettle so that she makes sure that she takes her medication in the morning. The photos, having the photos around, because that helps bring her joy. We're listening to a lot of this messaging. It's a lot of empowerment here. And that's taken away from her. She talked about her fears of not being able to remember who her daughters are. So that's why this conversation is so important. And I have to say, it puts a smile on my face when I hear her talk about the Great British Bake Off. Now, I am assuming that that is a TV show like we have here in the United States. This was actually filmed in the, over in England, that it's a bake-off show. And she gets to keep rewatching the reruns because she can't remember who won and who got knocked off every week. So that positivity, because she's been able to create that for her life. So how can we do this for those that we love, and to make sure that they get the life that they deserve to have? So as we're continuing this conversation, I just want to make sure that we're all really understanding. Just quickly, this is, if you see on the left-hand side, that would be the cross section. So if it was crossed this way, if that would be the cross section of what a brain would look like if it was considered normal. And then the other side is a cross section of the brain with somebody that has Alzheimer's. You see a lot of differences there. One looks plump, it looks filled, it looks like it's working. On the other side, the one with the Alzheimer's, it looks dehydrated, it looks sick, it doesn't look good. So we can't blame people that have these diseases for how they engage in our world. Their brain is not operating like it used to. They used to have the brain like the brain on the left-hand side of the screen. And now they have the brain on the right-hand side. We can't expect for their world to look different. We can't expect for them to be able to process like they have in the past. These are really important things to remember, to create that empathy and that sense of how can we do better. So some things that we can do is think about, how do you communicate? If I had that brain that wasn't working well, what are some things that would help me to be able to know that you're talking to me, that you're communicating to me? So you want to make eye contact. You want to be at the person's level. You want to make sure that you tell them what you're going to do before you do it. Don't just take them, lead them by the arm. If they're in a wheelchair, don't just start pushing them away. Explain, talk, prepare. You want to speak calmly. You don't want to be overexcited. You want to speak slowly. Short sentences work best, not long dissertations on why you're doing whatever it is that you're doing. I'm taking you to the bathroom. We're going to the bathroom. Short. And only ask one question at a time. If you want to know, are you hungry? Don't say, are you hungry? What would you like for lunch? Are you hungry? What would you like to eat? Breaking it apart. Try to stay away from the word remember. That's just kind of digging it right into people. Don't try to stay away from that word. Turn negatives into positives, like Wendy did about the British Bake Off. Turn that into a positive. The pictures of that fear of not being able to remember who her family is, putting pictures up and talking with her daughters about this. And the biggest piece that we can all get caught into is this arguing piece. Mom, I told you this yesterday. We're going to the doctor. How many times do I have to tell you? That's not going to get us anywhere. So we've got to make sure that we take a look and that we pull back, we take deep breaths, and we enter into their world as opposed to having them try to conform to what's going on in our world. So here are just some helpful interventions. Some of the things that we want to do is you want to provide meaningful experiences for people. Know who they are, what has meaning and value for an individual. If they like to be outside, if they were always somebody who liked to go outside, give outside as part of that experience for them. It has to be meaning and value for that individual, not for you, not for the general world, but for that particular person. If they're a person who likes to read the newspaper, even just giving them a newspaper to hold, they might not be able to read it anymore, but who cares? That sense of having the newspaper might give that meaningful experience back to the individual. Try to minimize stress. Really monitor what is causing stress for the individual and what isn't. And we're going to talk a little bit more about exploring this stuff deeper, but be mindful. When is this stuff happening? When am I starting to see the change in my loved one? Always make sure that you maintain the individual's dignity and self-esteem. I think many times we use this word caregiver. A better word to use might be care partner. To be a care partner, to keep the self-esteem, not to dive in and do the task. Instead, have them do the task and we're there to assist. Don't take away cooking. Let people continue to cook, but do it in a different manner. Maintaining that dignity, that self-esteem. Because also you've got to remember many times it's a role reversal that's going on. The mother might have dementia and the daughter becomes the care partner, right? And now as the daughter, I am trying to tell my mother the way things are going to be done. That may not play out very well for mom. So being mindful of that. As the daughter, if I start taking too much control, I might be stripping my mother of her self-esteem and her dignity. I've got to be aware of that. And only orient to reality when needed. If they're calling you the wrong name, who cares? If they don't know the right date, who cares? Only do this, only be mindful and provide with that orientation information when it's necessary. And it could be maybe about pills. We take pills in the morning, we take pills in the afternoon, and we take our pills in the evening. So it's not morning right now, Mom, so we don't need to do that. It's not lunch yet either. We're already good. I'm providing a constant routine during the day. If you can set up consistency, then people start to learn what to expect. And also it gives us as care partners being able to know how we could tweak things so it can go better for the individual experiencing dementia, but also for me as a caregiver, because we also have to be mindful of that. And we're going to talk a little bit more about that in a minute as well. And with that, looking at that routine, you want to make sure that we look at skills that the person has, those existing skills, and then engage people accordingly. So they might not be able to cook a full meal. Could somebody shred carrots for a salad? Could they take the lettuce and pull it off of the head? Some things that people can do. Can they pour water? What can they do? Can they measure? Can they get the measuring cups out of the cabinet? Just looking at tasks that people can do and making sure that they get broken down into those simple steps, not overwhelming. Another piece to be mindful of is to not overstimulate. So you're trying to cook, you've got the radio going, you're talking loudly, that might be way too much for an individual. So maybe you don't play the music, or it's very calm, soothing, and it's off over to the side. Also, provide the individual with the opportunity to have quiet time so they can take deep breaths, refocus, get back, feel in control, and not feel overwhelmed continuously throughout the day. So that brought us to the next one, the minimizing the noise and crowds. That can be overwhelming for people. I'm using memory aids. Wendy, she used that calendar that she kept on her refrigerator. Looking at that, what might work, what might not work, and trying to, sometimes I've seen some people that are experiencing dementia use a lot of stick it notes. Stick it. It could even be, this is the bathroom. Your phone is always in the front entranceway when we come in, making sure that they get those little cues and sticking them all over the house for when questions pop into people's mind, they know where to be able to look. You talk, using language, talking slowly, simply, demonstration. I do a lot when I'm talking with somebody with dementia, I do a lot of using my hands. So I might say, are you hungry? Are you hungry? And using some symbols that might help cue somebody into what it is that I'm asking. Are you tired? Getting tired now? Letting them see and having my body language go along with the words that are coming out of my mouth. Whenever I'm introducing myself, I always will go, my name is Lee, and I show my name tag, and I'll show them the name on my name tag. I usually get them taking my name tag, and they look at it, and then they'll see, and it helps make that connection. Allow space for people. Don't confine too much. We really need to take a look at that. Many times when we're in long-term care communities, we are confining people to very limited rooms. And then we wonder why they get up and they want to leave the room. They want to wander. We're going to talk a little bit more about that as well. Try really diligently not to argue. Instead, try redirection, distraction, and validating. I think that's one of the most important things that we can do. So when somebody is getting upset and they're like, I told you that I was hungry, say, I really hear right now that you are upset. I really can hear that. You're upset. Let me get on that and I'll get you some food. Acknowledging that they're upset. I think that that can, right there in itself, can help people know that they're being recognized for who they are and that you're valuing the emotions that they're experiencing as well. Present tasks, discussions related to past lifetime experiences. Try to make sure that their world, you're not forgetting about their past, that you're also bringing it in. And if they don't remember it, tell the stories, tell those wonderful stories and say, and you were a part of that, so they can feel good about the experiences that they had in their world and not fearful of the experiences that are to come. And then this is what we really want to do. We want to learn to figure out if we can figure out what's causing what's going on and then try to avoid this. And then make sure that the long-term care community that your loved one is in, it gets put onto their care plans. And so the bottom line is here, we really want to try to understand who the person is. Because if we don't, that's what leads to this. So I want you just to think for a minute. Adverse reaction, what does that conjure up to you? Or if I was to say behavior. Behavior to me has a very negative connotation. You know, we look at it with children. You better behave better. That kid has a behavior problem. He doesn't listen to anything I say. We put that term behavior to connotate negative. Whereas if I use instead a reaction, what is the person reacting to? Now that gives me the opportunity to explore what is going on. What is it that the person's reacting to? A behavior becomes this thing where that's just who they are. They behave this way. And I just don't get it. And that's just the way it is. Whereas if I say it's a reaction and it's an adverse reaction, why are they reacting this way? And then it gives me the opportunity to start looking at and exploring what's actually going on. So I want you to try to look at the language that you're using when you're talking about your loved one and you're trying to explain what's going on in their world. So let's think about this as inappropriate. It shouldn't say inappropriate, to think of inappropriate behavior not as a symptom of dementia, but as a response. I don't believe that dementia and behavior are interrelated. Yes, there are types of dementia-related disorders, that behavior is a characteristic of it because that's how the brain is affected. But not all dementias are that way. The behaviors that we see are a response to what is going on around them. So that's where I want to reframe this to an adverse reaction. Also, it's really important to recognize that there's no magic solution. What might work one day may work not at all the next day. And it really becomes a system of trial and error. And sometimes you get something and it sticks and it will always work. But then other times it doesn't. But that doesn't mean that you give up. It means you keep trying. You keep trying to figure out, how can we do this? One of my jobs in my past has been to consult. I did a lot of consulting with long-term care communities, with dementia units. And I would say, you know what, that's the thrill of this job, is that it's never a boring job. And we get to always be exploring and understanding and trying to process and really become those detectives. To me, that is what a care partner is all about, trying to explore and figure out what is going on with the individual. And again, what might work one day may be completely ineffective the next day. And don't feel that you've messed up, and don't blame the individual. It's just a part of this world of dementia. I'm going to show you something else now because I want you all to see this. Think about it. I'm going to stop it in between. What I really want you to focus in on are the words that not the narrator saying, but the words that the people in this are saying. It comes up very quickly, and it starts before we even see anybody with anybody on the screen. Okay.
Look at my hair. Look at the way they did my hair. You just stand there, Rose. Go to hell.
Okay, I want to stop it there and just talk about what we just saw. So that individual, before we saw a picture of her, she said, look at my hair. Look at how they did my hair. And the staff's response was, we just did that, Rose. And then we see Rose and her caregiver. And we see Rose looking at the back of her caregiver, and her caregiver is mumbling something under her breath on top of it. And then we see Rose grab the caregiver's back guard and start to pull it. Who do you think caused that behavior from that individual? I want you to think about that. Who caused that? Was it the person because they have dementia? So they pull her thing because they've got dementia. Or could it have been because she didn't feel listened to? Could it have been because she felt discarded? Could have been because she didn't feel cared for, because she didn't like the way her hair was done. And this other person's like, well, we just did it. The task was done, so we can move on to the next task, as opposed to the care situation, the care opportunity. What could have been done differently in that situation? Could the caregiver have stopped the task of making the bed, which to Rose at this point, the bed was becoming more important than she was. Getting that bed made was more important than getting Rose's hair, her need to have her hair look better. And that isn't fair to that individual. So could the caregiver, let's say she had to get that bed made for some reason, could she have stopped, given Rose a brush and said, here, Rose, here's a brush. Why don't you start brushing your hair? I hear you don't like it. Let's do that in a minute. Can I just finish making this bed? Or how about you help me make the bed, Rose, and then let's do your hair? Or how about stop making the bed and just work on Rose's hair? Would we have seen that behavior of her trying to twist and get that anger out? I'm going to continue this now. I want you to see the next scene. You will start to hear a narrator's voice coming on. Pay attention more to what you're seeing on the screen and hearing from the people that are in the scene.
There are many words for the behavior we see: acting out, disruptive, combative, agitated, aggressive. Aggression is regularly directed at staff, often during personal care. But aggression also erupts between residents.
Okay, so I want to take a look at that one. The lady in the shower particularly. Did you guys see the look on her face? If looks could kill. She was so angry, so upset. She was screaming at the beginning of that interaction with that staff member. What was she reacting to? Was that just a behavior because she's got dementia? No, she was reacting to something. Was she reacting to being naked in front of a perceived stranger? Was she reacting to maybe being in pain because the staff member was kind of handling her a little aggressively? What was she reacting to because getting the clothing off was being done in a very rough manner? I feel like she was reacting. And if staff would have done things differently, what would that experience have been like for that individual? These are the things that we need to start asking ourselves when we're seeing behaviors being demonstrated throughout long-term care communities. We're going to show just a couple of more here.
Don't scratch me again.
Don't mess in here. She and I are playing, not you.
You got a temper that makes you. Shut up. That's not mine. I think.
Sometimes
And that's
agitated, aggressive behavior becomes so troubling.
And so that's what I wanted to show us next is now the next engagements were resident to resident interactions. And this is what can start to happen. If people don't feel valued, they don't feel listened to, they start to take it out on each other as well. If the staff are not engaging and interacting well with the residents do not engage and interact well with each other. You're going to start to see resident to resident aggression. I am a firm believer in that. So one of the things that I will always ask when I see that there's resident to resident issues going on in a long-term care community, I stop and I want to say, how is the resident to staff interaction? Are the residents not getting what it is that they need there? So that they're doing is they start to take it out as well onto each other. So I just wanted to share that because this here then is what I want to bring us back to is now getting into what can we do about this stuff. So I need to go back to my share and bring my video back up. Excuse me, it didn't take me to my right place. So what I'm showing on the screen now is actually called Maslow's hierarchy of needs. If anybody ever took a Psych 101, we had to learn about all the different theories of practice for psychology, you probably heard about Maslow. And that is actually when I fell in love with this guy. Because I really believe that this is a perfect model to be able to use to start exploring what's going on with residents that live in long-term care and or residents who just are experiencing a dementia-related adverse reaction. So I want to take us through this because if you were like me, you probably forgot exactly how this works. But it's pretty basic and pretty easy. And one of the reasons why I like to use this is because this model actually is used in nurses' aides training. So when I share this with the nurses' aide, I say, do you remember this triangle from your training? They're like, it looks familiar. I'm like, yeah, you learned about it when you had your nurses' aide training. So I think it can be really, really helpful when we're talking with care partners on how they can explore what's actually going on with an individual so that to help minimize these adverse reactions. And when those adverse reactions get minimized, it's better for the individual experiencing the dementia as well as for the care partner, because it makes things go together better for people. So let's start. The way this works is just start at the bottom of the pyramid. And no, it's not the food pyramid. It is Maslow's hierarchy of needs. So the bottom need is physiological need. And if you really look at Maslow's real chart, he says food, water, shelter, warmth. I've added in pain and need to void because those are physiological needs. And it doesn't mean all, it means all physiological needs. And it just gives you an example underneath it. But I feel that when we're talking about the geriatric population that have a dementia-related diagnosis, we need to include pain and we need to include that need to go to the bathroom. Because many times this is one of the reasons why people start experiencing that adverse reaction. I am in pain. You're moving me down the hallway. Every time I'm going down this hallway, I am experiencing more and more pain. So I'm screaming now as we're going down the hallway. By the time we get to the destination of where you're taking, I am in so much pain, I'm hauling off and punching you. That can happen. I need to go to the bathroom. I can't communicate this too well. So I'm screaming out. Nobody's giving me the time of day. I need to go to the bathroom. And nobody is even listening to me. I'm getting very, very upset. So now I'm going to trip the person who just walked by me to get the attention that I need. Think about this. So if we start there, every time we see an adverse reaction, if we start and we take a look and we say, could there be an unmet physiological need? Could the person be hungry? Could they need to go to the bathroom? Could they be in pain? Could they be cold? Could they be thirsty? And trying and seeing, does that make the world better for that individual? It worked, yes. Or it didn't work. So now I need to move to the next tier. The next tier being safety. And what is safety? Safety is that stability, that freedom from fear. I want you to think about Wendy and how she shared her shared experience of having dementia. She talked about her fears, didn't she? And if she has those fears, that she doesn't recognize her daughters. So people are coming in, she doesn't recognize individuals. That can be very fear producing. I don't know where I am. I don't know anybody around me. What am I to do? I'm scared. Where am I? I'm lost. This can be a very fearful situation for individuals. There's things that we can do. If you always have the same care partner, if you're in a long-term care community, why can't the same nurse's aide care for the same group of people all the time? Create a deeper sense of community. Then there starts to be that expectation to learn a routine. We talked about routine is good for people that have a dementia-related diagnosis. And it also, the expectations of what they can do, what they can't do, how I can empower them more. These are all things that can happen if we look at this safety piece and we provide some interaction onto that, making sure that people are aware of where they are. If they say they need to go home and you say this is your home, that could produce some fear. That can produce a lot of fear. Why can't we go to the core of the matter? Which brings us up to the next rung, belonging and love. Could home actually mean I need a sense of belonging? I need to feel loved. Could that what home mean? And I'm not feeling that way right here. So because of that, I keep going back to my safety piece and now I get scared. People need belonging and love. I mean, if you think about it, we even with cats and dogs, we pet them, right? We let them know that they're welcomed. We let them know that we care about them. What do we do from people that have a dementia-related diagnosis to show that we care? How do we show that we care? Family members can show their care in different ways than staff members, but that does not mean that a staff member cannot show belonging and love to an individual. Sometimes just saying, "How are you doing today, Betty?" Betty may not remember who that person is, but because they had a big smile on their face and they said, "How are you doing?" They might start to feel like, she cares about me. This is that person. I know that tone to that voice. I don't remember who she is, but this starts to increase a level of comfort. Another thing that I've heard from people that have dementia, I've done a lot of conversations with people with dementia. And one of the things that I have learned from many of these conversations is they have said to me, I might not remember what you said, but I will remember how you made me feel. That's that belonging and love. So think about that. It's all those communication techniques that I went in. How do you use your voice? How do you approach? How do you show? Do you smile? Do you show recognition? Do you let them know that you are a caring individual? Or do you walk in and say, it's time for this and we're going to do that, and be task oriented? If you are doing it in a way that's not good for that individual, I can guarantee you're going to start to see adverse reactions happening. The next rung
Hey,
is this.
Lee,
Yes.
on the belonging and love, you mentioned um, being able to remember how uh, the other person made them feel. Um, that emotions are stored in a lot of different places in the brain. And so
Mhm.
that's why I'm just trying to expand on what you've said already, but that's why people with dementia will sometimes swear more because there's an emotional connection with that word. So it's stored in more places. Some people with dementia will also hold, hold baby dolls, because there's an emotional connection with their memories of holding their own children. Um, I posted a news article in the chat about uh, Supreme Court Justice Sandra Day O'Connor's husband, who lived with dementia, lived with Alzheimer's in the last years of his life. And the article is about her husband and his girlfriend, who also had Alzheimer's. And she said she was very supportive of his relationship with his girlfriend because he was more relaxed, he was happier, he had that belonging and love.
Mhm.
And I think it's a very important aspect.
It really is. And we skip over that many times when we're doing the care. We go too much to the task. We don't work that in, and we need to look at how we can work that in. And that brings us right to the next thing as well, this self-esteem. Many caregivers' nature is to care, and to care a little too much sometimes, so that we take over and we start doing everything for the individual. And sometimes we do it because we feel that that's our job. I'm the caregiver, so I give care, as opposed to I'm the care partner who's here to assist you in how you need the assistance to get your care happening. And that can be think about how we rip people's self-esteem all the time when we're feeding them all the time. Why do I need to cut up a piece of chicken for somebody? Why can't I just give them the entire chicken breast and let them eat that chicken with their hands? Why am I I've seen people take sandwiches and cut sandwiches for individuals. I don't get that. All we're doing is making them then dependent on us. Eating with your hands is a lot easier than to eat with a utensil. That can be complicated for individuals. I mean, my daughter, I have an 18-month-old grandbaby, and that grandbaby eats with her hands because it's promoting self-esteem, independence, and it's also easier as a caregiver, a care partner. My daughter can eat her dinner while the baby's eating her dinner. And they can be up together. And it's not like you're doing a task. So I think we need to really use this. And then the last rung on this is self-actualization. And that's allowing people to feel confident and comfortable and to really, really pursue who that inner person is, being everything that they possibly can be, valuing the individual for who they are, not who they were, for who they are, and being with them at that moment in time and valuing them for who they are at that moment in time. I will encourage you to use this. If you feel that the care in your community is not, in the long-term care community your loved one may be in, is not what it is that you want, run a copy of this presentation. It's going to be on our website. And Stephen, I know, has put those links into the chat. You can run a copy of this whole thing. You can point them to this video. You can point them to the website. Tell them, have you looked at Maslow's hierarchy of needs and used that to explore? Because this is what I do whenever I would see an adverse reaction. I would use Maslow to help me understand What is happening? When and where is that behavior exhibited? Who is involved in the behavior? Why did the behavior occur? What now? And the biggest question we can ask, is behavior really a problem? If so, for who? Is it a problem for the individual? If it isn't, maybe I need to swallow hard and just take it. That individual will ask questions over and over and over and over again. Is that a problem for the individual? Maybe not. Is it a problem for me as the care partner? It can get a little tiring. So maybe I just need to give the answers, think about other things that I can do. Maybe I can give some cueing to make it better. Maybe I can say, let's find the answer together instead of always being the one to give the answer. Things like that. See how we can do it. So I want to take this investigation now and take a look at some common situations that we might encounter when someone has a dementia-related diagnosis. Wandering. We hear this one all the time. Could it be exploring instead? Let's think about that. Sundowning, bathing, shouting out, and then some mealtime issues. So I want to take each one. Wandering. So what's really happening? Are they really just trying to explore? Does the individual just want to get up? Oh, I see a door. What's behind that door? I'm curious. I want to get up and open that door and see what's behind it. It's piqued my curiosity. I've been looking at it all day. Or could it be, I've been sitting for a really long time and I need to get up and I need to move? Or could it be, my butt's starting to hurt me? I've been sitting and my butt hurts. I need to get up. I need to move. I need to get some circulation. So wandering, is it really a problem? Is it really an issue? The only time it becomes an issue is it's persons that fall, threats for falls. So walk with the individual. We can all use our steps. We have these, many of us have these devices on our wrists that we're counting our steps all the time. So why not get up and wander around with the individual? Think about when and where. So can you pre-do it so that maybe at 3 o'clock is not going to be the best time between shifts for a staff member to go wander with an individual. So let's pre-do it. Maybe at 2:30, at 2 o'clock, say to the person, hey, you want to go for a walk with me? Anticipate what's going to be happening, because at 3 o'clock is typically when they want to get up and move. So let's do it before they even want to get there. So that way then I'm getting them to have that engagement, that what they want to have happen. Who is involved in the behavior episode? Does it happen? Why did the behavior occur? And what now? And then again, is it really a problem or is it not? Many times I find that wandering really is not a problem. I do not like to see people that have a dementia-related diagnosis where staff all day long are telling them to sit down. Sit down, Rose. Rose, sit down. Sit down. Why can't she stand up? Get up yourself, stand next to Rose, let her stand up. 9 times out of 10, she's going to sit back down within the next couple of minutes anyway, if she's non-ambulatory. But at least she got to stand up in an independent manner. You were there for the safety. You could be talking with her. It gave you those 5 minutes to be able to interact with her, and she'll sit back down. She was empowered. She got her need met, and everything is good. I want to talk about sundowning now. Sundowning. First of all, if you look in a long-term care facility, sundowning typically happens about 3 o'clock in the afternoon. What else is going on at 3 o'clock in the afternoon? I can tell you what's not going on. The sun is not going down. What's typically happening is staff are leaving. The change of shift starts to happen. Staff members are being kind to it, and they say, hey, Sally, I'll see you tomorrow. Hope we're on the same team. Have a great day, the rest of your day. People are saying goodbye to each other. People are grabbing their coats. Women are grabbing their purses, and they're walking out the door, right? So could somebody start demonstrating sundowning behavior because they think the building's closing? They don't know where they're going next. They have no idea what's happening. And when we use this term sundowning, we have now made it an excuse that we're not going to explore this behavior because we've given it a label. I do not like this term at all, because I've heard staff say to me when I'm saying, what's going on with that person? Oh, they're just sundowning. And then they won't explore it any further. I'm like, but why? Why is it happening? When? Who is involved? Why did the behavior occur? What are we going to do about all of this? I've had staff then say, instead, you know what, guys, I know you want to say goodbye to each other, but instead, just kind of give each other a little wink to say goodbye. Don't be shouting across the room. Just seamlessly walk off the unit and come, and the next person seamlessly walk back on. I've seen it done beautifully in the middle of a bingo game. An activity staff member was calling bingo, and it was that person needed to leave and the next person was coming on duty. And so that person said B6, and then the next person came in. It's like 072. 072. The residents didn't even know that the staff members made their change in shift, and they didn't create any havoc. Before that, things got very hectic and crazy in that activity room as staff were coming in and leaving, because it was very, very noisy. There's a lot of activity going on. Bathing issues. There are a lot of very dangerous things that happen in the shower rooms in long-term care facilities. A lot of staff have gotten hurt, and a lot of residents have gotten hurt in the baths, in the bathing rooms. Is it about the task there, or is it about the person? I hear people screaming outside the door sometimes when I go into a long-term care community, and it's just, I can't imagine what is going on inside that room. And for sake of privacy, I'm not entering into that room, because that might make the individual even more upset. But that needs to be explored, and explored deeply. This is an opportunity. Did we let the person know where we were going? Did they just get blindsided that they're taking a bath right now? Are they in pain? Are they embarrassed to be naked in front of a stranger? What is actually going on? There's a whole video called Bathing Without a Battle that I would recommend for any care partner to watch. It really does help give some very good ideas on what can be done to help minimize those adverse reactions that can happen when people are getting bathed and shouting out. I've been in so many long-term care communities where you hear people in their room shouting out, help, help, or even just shouting and moaning, and it gets ignored because, and I bring it to people's attention, that's just who they are. That's just what they do. And as opposed to exploring what is happening, why are they doing? Is their pain medication worn off? Do they need to be moved? Do they need to see that they're not alone? They need to be brought out of that room. Are they missing human contact? What is going on with the individual? And what can we do about it to make their world better? Mealtime issues, same thing, doing that exploring. What is going on with the individual? I do want to get to this point. I know I've really been talking a lot, and we haven't been able to engage as much as I wanted us to, but this antipsychotic drug use, that is not the solution. I am telling all of you, all 57 of you that are on this right now, going to have an antipsychotic drug is not the magic wand to reduce that adverse reaction in people. I want you to see what this says right there. Increased mortality in elderly patients with dementia-related psychosis. And it goes on to read about if somebody that has a dementia-related diagnosis is given an antipsychotic drug, and this is on all antipsychotic drug packaging, it's a black box warning that people are at a higher risk to die. So if you sign off on this as a family member, or if you are a nurse that's calling the doctor and saying, can we get this patient an antipsychotic drug, you are promoting death in that individual, because there is a warning that this should not be happening. And on top of that, Illinois is the worst state in doing this. Illinois nursing homes are overprescribing psychotropic medications to people that have a dementia-related diagnosis. Point blank, we are overdoing it. There is this Nursing Home 411, the Long-Term Care Community Coalition. We actually had someone speak to us about this last meeting to talk about how what a problem this is for people with dementia. This is not good. We should not be approving this. This should be the very, 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 very last resort. And I would never be a proponent of it for somebody that I loved. I'm just sharing that with everybody. So we really do need to make sure when you look on the site, the lower the number, the better. And it brings you this, when you go to the site, you can put in the state of Illinois, and it will show you exactly how your long-term care community is performing in regards to antipsychotic drugs. So you can bring that data, that information to your long-term care community that your loved one is living in and say, this is not, I'm not allowing this to happen. I want my loved one off. They need to be titrated off of this, and we need to start exploring why they're demonstrating the behavior, not putting a pill in their mouth. That is not, if a kid was misbehaving, you're not going to give him a pill. You're going to figure out, you're going to work with them, you're going to want to make him have a better experience in life. We need to do the same for those that are aging in our society. What we really should be doing is to keep this from even happening is to look at this concept called activity-based care. And that is part of what the regulations say for people that have a dementia-related diagnosis. And what that really means is we're not talking about an activity program. We're talking about engagement for people. And it can be a personal encounter, naturally offered by the environment. One of the things that I would always do is put a jigsaw puzzle out in every day room, in every nursing home that I ever attended, that I ever went into. Because you know what, people many times would just walk by and they might look at the pretty pieces, or they actually may start trying to put the puzzle together. That's what you call naturally offered by the environment. Having magazines out, having things out that people can engage in, and not to make them toys, baby toys, to make them adult things. Looking at daily housekeeping routines. Why can't a resident help make the bed in the morning? Why can't a resident help set the tables? Why can't a resident fold the napkins? Why can't a resident help do so many different things? Get a carpet sweeper and sweep the dining room after the meal. There's so many things that people can do. That helps with all of those things. If you start looking at that hierarchy of need, self-esteem, belonging, I belong here. I'm doing something for other people. Self-care activities, that should be considered engagement. So it shouldn't be about getting it done as quick as we can. It should be about taking a deep breath. And it might take us an hour to brush our teeth, but they were engaged. Thinking about how the dressing, the grooming, all of that, give the individual the brush. Don't just take it away from them and start brushing their hair. Give them the brush. Let them brush your hair. Work on things together. And then there should be some planned and scheduled events as well to help break up, but there should also be that opportunity for spontaneity. If you think about your own life or your loved one's past life, they had planned things, but they also did things spontaneously. So we want to make sure that we're offering all of that. And that activity-based philosophy is really making sure that activities are the foundation of every event, encounter, or exchange. And by that, I mean engagement, that they include those chores and all of those things, playing cards, paying bills, all of that is considered engagement. And it's the object of good engagement is not only to serve the best interests of the individual, but also to make it a rewarding experience for the person with dementia and the care partners, doing it together, coming together, having valuable moments together. That's what it needs to be more about. And they can be planned, they can be one-to-one, and they should be planned to address needs, history, strengths, and challenges of individuals. Recognizing that this is so hard on caregivers. Take this number down, all of you caregivers. It's a 24-hour-a-day, 7-day-a-week hotline number by the Alzheimer's Association. You will talk to people who know what they're talking about. It's staffed by psychiatrists, psychologists, social workers. That's who staff these lines. And they can help talk through things with you. They can be there to support you. I hope you take this number down. 800-272-3900. Again, 800-272-3900. I know we are literally 5 minutes over here, and I apologize for that. But I would like to continue this meeting going because I would like the opportunity for people to be able to share any difficult situations, and maybe we can problem solve this together. So I recognize that some people may need to leave, but if you want to talk and share, please do unmute your mic right now and share with us. So with that, I will just take the presentation off of the screen. Okay. Does anybody have anything? Or Stephen, I know I talked pretty quickly. I'm not sure. I see there are 28 comments in the chat, but I don't know if any of them are questions.
I don't see any questions. It's mostly just Karen and I talking or providing more information. But I did have a couple of stories to tell. So before coming to the state office, I was a regional ombudsman. I would go out to the nursing homes in my area and work with people there. There was one individual I worked with who uh, the staff were complaining that he was being aggressive with them. Like he would grab people, and it when I first met him, he went and shook my hand and he would not let go. He didn't understand to release the handshake. He was also um, he had lost his sense of his fine motor skills. So instead of giving a light grip like you would, a nice firm handshake, but still light, it was an
That grip.
iron grip. And oh, my hand hurt for quite a bit after that. And that is part of dementia that we don't think about a lot of times because we focus so much on memory loss. Um, I had another situation, and I bring this story up a lot. My staff was in the facility, and she witnessed this. Um, the resident was, the resident eloped and then attacked the staff who was trying to redirect her. Now, that's how it was written up in the staff reports, that she eloped and attacked the staff. What actually happened was the woman had been standing by the window for about 10 minutes looking outside. You mentioned, Lee, about behaviors being communication. She went to walk outside. She'd been telling everyone that she wanted to go outside for 10 minutes by looking outside. She walks outside and this stranger walks up to her and grabs her from behind. Now, that was the staff's attempt to redirect. Now, let me ask you, Lee, if you are in a strange place surrounded by complete strangers and somebody comes up to you and grabs you from behind, what are you going to do?
I'm going to be very scared. I'm going to feel
Mhm.
that my safety is completely threatened.
Yep.
I'm going to be nervous. I'm not going to know what's going on. And things are just going to start to escalate in my mind. I'm going to feel
Yep.
maybe I'm being abducted. I don't know what's going to be happening. I don't know. And I may start screaming and I
Mhm.
might even hit you.
Yep, exactly. And that's what happened. And unfortunately, this woman got sent to the hospital for attacking a staff when really her behavior was a natural and logical response based on where she was at in her mind. And so it's really important to look at a person's actions as being reactions and as being um, uh, communication for what they're needing and what they're feeling at the time.
And that I think is the piece that we all have to continuously remember, is that we need to do that exploring. And when we start labeling, and that becomes part of my pet peeve in our long-term care world, is we do a lot of labeling of things, like I said, with the wandering, sundowning, elopement. If your little kid is trying to go out your front door, a toddler of 2 years old, do you say he's trying to elope? Please, we don't do that, right? Why do you want to go outside? You want to go outside? That's what we'll say to the 2-year-old, right? You want to go outside? Let me take you out in a minute. We recognize that there's a need, that this individual wants to go outside. I'm not equating people with dementia in any way, shape, or form as being children, because that is not what I'm equating. But what I am equating is it's human needs. And then we start labeling it, and then we minimize the need to be a label. And that is uncalled for. We all have to take a long look at ourselves and see how we propagate this and we encourage this in our long-term care world. And we can't allow it to happen. And as family members, If some of you even work in the environment, I really would like for you all to just take a moment to reflect on how potentially you might be part of the reason why your loved one is reacting the way they're reacting, because maybe you haven't entered into their world enough to try to figure it out, because they're different and they never did this before. I see that we've got a comment that popped up. My mom is obsessive about locking the doors and then checking them 4, 5, or 6 times before she actually goes to bed. I usually go to my room, but if I don't, she will ask me if the doors are locked or tell over and over that she's locked the door. You know what? I love, Samantha, I love it that you're being honest. You don't always handle it well. That is perfect, because that's the first thing you got to do. You got to say, this is hard. I don't handle it well. I get fed up. It's the end of the day. I'm so exhausted right now. This is the last thing I want to do. So, maybe you start earlier before she goes to bed. Let's check the doors together to make sure that it is locked. Let's do this. Let's stand here until we feel confident and comfortable that these doors are all locked. And it maybe even develop a little check sheet for yourself. So you have all the doors in the house listed. Your mom helps write it out for you. All the doors. What's everything we want to make sure at nighttime that we've got, that we've got secured? Let's write that out, Mom. And every night, let's check it off so we can make sure that we did it the right way. I mean, these are just some ideas, and none of it is going to be magic. Like I said, that magic wand does not exist. But what you're doing is not working for you nor for your mom. So try another way. And maybe you'll wind up going back to the same old way you always did it. But you tried something different. And maybe just that change of routine gets her out of that obsessive compulsive piece there. I don't know if that helps you at all, Samantha, but I love, 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 love your honesty.
And
Go ahead, Stephen.
well, I was just gonna add, my old house, I had a door where I could see the deadbolt going into the frame. It's technically not the correct way of having it set up, but some locks are easier to see than others, and it
Mhm.
might make that check a lot quicker.
Yeah. Yep. Someone else was talking about whether or not it's important to get that true diagnosis. If there's benefits, because that can really be stressful for the individual. If you look at what Wendy said, it was relief for her to get the diagnosis, because then it gave reasoning to her. She wasn't going crazy. She wasn't losing her mind. I personally typically advocate for people finding out what type of dementia you have, because it does present differently and different medications can be there. For example, if it's Lewy body, there are medications that can help with that loss of fine motor control that they may be experiencing, which can be extremely frustrating. So there are things that they can do for that. That frontal temporal, just knowing that if somebody can't control their emotions as much, that could be because they have frontal temporal. And if they having that, then I might know that could be part of that disease process. So maybe I don't want to dive too deep into that. Mom just gets upset and can rant and rave, but then the deep breathing is what works, because there is no logical reason for really what's going on there. So that exploring part, I might just keep exploring, and I can never figure it out. But it could just be because it's that part of the brain that actually was being affected by that. So
Yeah,
I typically advocate very strongly for people to get a diagnosis and to go to an expert in that, not just your general practitioner, to go to somebody who's a gerontologist who specializes in this. And many of the university doctors are who you want to go to, because they're on the cutting edge. We've got a lot of medication that is coming out that's even helped to be able to stave it off and or slow the progress of it.
and Lee, to add to that, it can be reassuring to know, because like frontal temporal dementia, your frontal lobes is where your social filter is.
Mhm.
And the creepy old man trope, a lot of that comes from the breakdown and the loss of that social filter, because when that social filter breaks down, that's when you don't really care if you say or do inappropriate things.
Mhm.
And I was talking to a office neighbor at my old workplace, and just kind of talking about different types of dementia. I forget how it came up, but when I talked about inappropriate behaviors, that was such a relief for him to hear. And he told me that because he said, okay, that explains why my mom did and said all of those things at the end of her life, because she was a completely different person from the one he grew up with. And so it was reassuring for him to know why that was happening.
I've heard people say to me, my mother never swore a day in her life, and now all of a sudden she has dementia and she's swearing up a storm. She swears all the time. And many times, it's that part, that filtering part, not being able to really stop that because they don't have that filter anymore.
Mm-hmm.
Does anybody have anything that they want to bring up, anything they want to talk about? I want to encourage you that if you are experiencing any breakdown with your long-term care community in how they might be dealing with your loved one, again, reach out to your ombudsman so they can help advocate with you on, let's explore these behaviors. Let's explore what's going on. Let's change the way we look at it as a behavior and start looking at it as a reaction and see how we could do this better. Because that's what this is all about, doing better for the individual, while you as caregivers are also knowing that you're not doing anything wrong, that you're supported. And that's why I really want to encourage you guys to reach out to the Alzheimer's Association for that support number.
Yeah.
And there are a lot of support groups in the area, so look for that as well. The Alzheimer's, they can help you very much with that.
Yeah, the more, and just to reiterate, like, if you have a loved one with dementia, you love them, you want to care for them. But if you are not taking care of yourself, then the chances of you abusing and neglecting your loved one skyrocket. If you've ever flown on an airplane, they tell you, if those bags drop, you put your bag on first, your oxygen mask on first before you put your child's on. And the same is true here. You have to take care of yourself first, because if you don't, you won't be able to take care of your loved one, whether it's a child or whether it's an adult.
Very, very well said, Stephen. And with that, I'm going to go ahead and I'm going to stop the recording.